Welcome back to the podcast, everyone. I'm Dr. Khan, and today we are diving into one of the most common yet frequently missed injuries in the emergency room. Picture this. It's a rainy Tuesday, and a young athlete comes in after a foosh. That's a fall on an outstretched hand. They've got some wrist pain, they're pointing to the base of their thumb, and they're hoping it's just a sprain. But in the back of your mind, a red flag should be waving for the scaphoid bone.
And for good reason, Dr. Khan. From an academic standpoint, the scaphoid is the most frequently fractured carpal bone, accounting for about 60 to 70% of all carpal injuries. For those of you prepping for the boards, remember that the scaphoid bridges the proximal and distal rows of carpals, making it structurally essential but mechanically vulnerable during hyperextension of the wrist.
I like to think of the scaphoid as the keystone of the wrist. If that keystone cracks, the whole arch is in trouble. Now, Sarah, when we're examining this patient, we always look at that little triangular depression at the base of the thumb. We call it the anatomical snuffbox. Why is that such a high-yield area for examiners?
The anatomical snuffbox is a classic board favorite. You must know the boundaries. Medially, it's bounded by the tendon of the extensor pollicis longus, and laterally by the tendons of the abductor pollicis longus and extensor pollicis brevis. The floor of this box is where the scaphoid sits. If a patient has point tenderness right there after a fall, you treat it as a fracture until proven otherwise.
That point tenderness is everything. But here's the kicker, and this is where it gets tricky clinically. Sometimes the initial x-ray looks completely normal. I've seen residents clear a patient because the scaphoid view was negative on day 1, only to have the patient come back 2 weeks later in agony. Why does this matter clinically? Because if you miss that window, you are looking at a disaster for that bone's survival.
Precisely. The occult scaphoid fracture is a major exam pearl. If clinical suspicion is high, but imaging is negative, the standard of care is to place them in a thumb spica splint and re-image in 10 to 14 days. By then, bone resorption at the fracture line usually makes the break visible. Alternatively, an MRI is the gold standard for early detection if the patient needs an answer immediately.
Let's talk about the why. Why is this bone so fragile compared to its neighbors? It all comes down to the plumbing, the blood supply. Sarah, explain that weird retrograde flow that the textbooks love to emphasize.
This is the highest yield fact for this topic. Unlike most bones where blood flows from the proximal end to the distal end, the scaphoid has a retrograde blood supply. The major branch of the radial artery enters the scaphoid through its distal pole, or its waist. This means the proximal pole, the part closest to the radius, is entirely dependent on blood that has already traveled through the rest of the bone.
Think of it like a garden hose. You're trying to water a plant at the very beginning of the hose, but the water only enters at the very end. If someone steps on the hose in the middle, that's your fracture. The plant at the beginning gets nothing. It withers and dies. In medical terms, that's avascular necrosis, or AVN.
Exactly. A fracture through the waist of the scaphoid effectively cuts off the blood supply to the proximal fragment. Without blood, the osteocytes die, and the bone undergoes creeping substitution and collapse. On an X-ray, this looks like the proximal pole is getting whiter or more sclerotic compared to the surrounding bone. That is a sign of ischemia.
And that leads to non-union, where the bone just refuses to heal. Why does this matter clinically to the patient's life? If that bone doesn't heal, the wrist mechanics shift. You get early onset osteoarthritis, chronic pain, and a significant loss of grip strength. For a 20-year-old athlete or a manual laborer, that is a life-altering complication.
It's also important to note that the scaphoid is largely covered in articular cartilage because it articulates with the radius, the lunate, the capitate, and the trapezium. Because it's so slippery and bathed in synovial fluid, there isn't much periosteum to help with secondary bone healing. It relies almost entirely on primary healing, which is why stability via casting or a compression screw is so vital.
I always tell my students, when you see that snuffbox tenderness, don't be a hero and just give them a wrist brace. You need to refer them to a specialist who can manage the long-term risk. You want them to see their doctor of choice for orthopedic follow-up to ensure that thumb spica is fitted correctly. Missing this is a one-way ticket to a malpractice suit and a very unhappy patient.
To recap for the boards, scaphoid fractures are caused by foosh. Look for tenderness in the anatomical snuffbox. Remember those APL, EPB, and EPL boundaries. The blood supply is retrograde from the radial artery, entering distally. Therefore, a waist fracture puts the proximal pole at high risk for avascular necrosis and non-union.
Spot on. Energy-wise, I always feel for these patients because the recovery is long, sometimes months in a cast, but it's better than a lifetime of a clunking wrist. If you suspect it, splint it. That's the golden rule. Thanks for joining us today for this deep dive into the carpus. We'll see you in the next episode.